Welcome to our video history project for the American College of Obstetricians and Gynecologists. Today, we're very fortunate to have Dr. John Nettles, better known to most of us as Jack, to tell us a little of his experience and his involvement with ACOG. Jack, thank you very much for being here with us, and thank you for your willingness to share your ideas. I'd like to begin with a little bit of your past history so that our viewers will be able to understand who you really are.
Yeah.
You just told me that you're 2 days from your birthday.
Yeah.
Where were you born?
Born in Dover, North Carolina.
You're a Tar Heel.
Tar Heel. Moved away when I was less than a year old.
We understand about that. When did you first decide that you wanted to become a physician?
I don't know. I think it's in my boyhood. I sort of decided between the various things, and medicine kept being towards the top or at the top.
And when you decided to go for your undergraduate training, where did you go?
University of South Carolina at Columbia.
And to medical school?
At the Medical College of South Carolina, now the Medical University of South Carolina.
That was a change that took place not too long ago.
Yeah.
What do you think they changed?
Just the sound. Well, they have pharmacy, nursing, and all the others, and I think they wanted to make it a true university.
During your medical school career, what prompted you to think about becoming an obstetrician gynecologist?
Well, one is I wrote a paper, and it was on an OB topic. It was published in the State Medical Journal. It's on pregnancy spacing in South Carolina from the public health standpoint. And I think that firmed it up. Plus, there's always a family friend that was an obstetrician, and that helped it along.
Now, when you took your residency, was that also in South Carolina?
No, that was at University of Illinois Research and Educational in Chicago.
And of course, you realize I'm also
Yeah.
trained there also.
Yeah, we have a reception tonight.
Yes, we will have one. When you got to your residency training program, how did you feel about training in a city like Chicago?
Well, actually, the first year was at Manteno in an affiliated program. So it was a gradual transition into Chicago. And so I just took it as a matter of course.
Chicago has a rich history with our specialty since actually the college originated in Chicago.
Yeah.
Did you have a chance to ever meet any of those forefathers of our specialty?
Oh, I met many of the Chicago people. And of course, Davis and Diekman in that group. DeLee was a little ahead of me, knowing him. But Davis and Diekman and all the Northwestern group. And of course, Fred Falls was at Illinois, and Bacon, who'd been a previous chairman there. So, and there were Greenhill, of course, was big.
Tell me what you thought about Fred Falls.
He was an odd guy. In fact, I'm not a founding fellow of the college because of him. He said, I don't know if this organization is going to go. He was big on the American Committee on Maternal Welfare. And in fact, Don Richardson was the exec for that organization before he came to the college. And he was not very supportive of the founding of the college. He wanted to make the American Committee on Maternal Welfare national. Well, there was a national group, but to include more physicians. It included not only physicians, but included nurses and laymen and anybody who wanted to join.
Now, when you decided to become an OB-GYN, what would you describe as the key factors it helped you make up your decision?
Well, it's hard to say. One is I had an aunt who always kept saying I'd be good as a physician, and she was married, widowed of a doctor, And then that sort of got me started. Then there was Dr. Robert Siebels, who was big in the South Atlantic group, who was Columbia, who was a family friend. And it just seemed to be broadly oriented, the way you're a specialist but still a generalist, as we've gone through a lot of discussions.
Yes, and a lot of changes. Once you finished your training, where was your next position?
I stayed on at Illinois on the faculty.
How long were you there?
Well, there were 2 years of that. I was away on my second tour in the Navy. In the first two, I had only 17 months instead of 18, so I had to go back for a full tour after that. And then I was doing work on the kidney biopsy and so forth, and toxemia, and that a little bit more of it, and more severe ones at Arkansas. And of course, Bill Menger was a good friend of Willis Brown, and we all got together and decided maybe I'd go down to Arkansas. And so I moved to Arkansas from there.
What years were you there?
I went in 56 and left in 69.
At Arkansas?
Yes.
And where did you go from Arkansas?
From Arkansas, I went to Tulsa. At that time, I was the Secretary-Treasurer and Chair-elect of District 7. And Adolph Furman, who later became Treasurer of the college, was from Tulsa. And we talked a lot, and it seemed to me that there wasn't much use in building a lot more Grady's and Bellevues and Cook counties when we had a number of large community hospitals who had very high quality care. In fact, when I was on CREOG, we used that as an example of moving towards getting universities getting involved in the community hospitals. And I was the first one to do that. I think Walt Cherney was the second. But it just seemed to me to be a good thing, and they talked me into it.
Let me take you back to your Arkansas years, because you were there with Willis Brown.
Yes.
He has a relatively interesting, I'll have to say, reputation in our specialty as being fairly dogmatic. Would you say that was true?
Well, he was. He was a very close friend of Bill Mengert. And they, of course, were both dogmatic. Also, he had trained under Ploss at Iowa, and this led to a certain amount of dogmatism. So I think it was sort of inherited a little bit from his background.
I remember him giving a lecture at Illinois where he told us that the management of preeclampsia was just to put him in a room, turn off the lights, and shut the door.
Well, he ran an interesting experiment where he spent one group of patients where they just treated the convulsions and paid attention to that, not much else, except symptomatically. And another group for bed rest, and let's see, we had 3 groups: control convulsions, control the blood pressure, and I think nothing. And he found out it didn't make that much difference as long as you gave general supportive care. And he liked to quote that a lot.
Yeah, he was very interesting. When I was at Illinois, Mengert was the chair there, and they were close friends.
Yeah.
Well, when you were in Arkansas, what was your major academic interest?
Well, I started out with the kidney biopsy, and we finished the work. It was done with the group at Illinois, Clark and Pollock and Perani and that group. And then I graduated more towards the public health phases of Ob-Gyn.
And when you moved to Oklahoma,
When I moved to Oklahoma, it was really focused more on trying to bring the community hospital into the university. Jim Merrill at the boards one year, and Adolph Furman had been talking, and they sort of wondered if I would be willing to come to Tulsa and have an appointment with the university and be based in Tulsa. And it worked out, and I spent 1 year at Oklahoma City in their clinic, went to grand rounds in the morning, a department business meeting, and then the clinic for a half day, and had an unmodified appointment, even though my salary was paid through Hillcrest at Tulsa. It was sort of like the VA system in the salary and unmodified appointment.
Did you have an opportunity to do research there?
Not much. It was sort of busy. But we did work some on the Tatum T, copper T, which was clinical. Didn't do any basic research there.
And how long did you stay there?
Well, I'm still there.
You're still there.
40 years.
If you had it to do over again, would you make the same decision, knowing what you know now?
I think so. I think the community hospitals have played a major role, and as usual, and true for universities, some are better than others. But I think it has been a major contribution to use the community hospitals for residency programs.
How many residents do you have in your program today?
We have 4. At 4 years, be 16.
Is it a freestanding residency, or are you associated with the university?
Well, it is a University of Oklahoma at Tulsa, which is now called the School of Community Medicine.
Why community medicine?
Well, one of the reasons I went to Tulsa to bring it in, and that philosophy is now generally accepted. And we have always been working together with the Indian Health Service, with the neighborhood health centers. We developed the 3 community hospitals into one program. And then when the university came in, the Tulsa branch, the residency programs became the core of the departments in the medical school. And since then, of course, we got, I think it was $30 million, a large grant from the Tulsa Kaiser Foundation, and they're interested in increasing the community involvement in medical health and in education. And so it sort of evolved that way.
Let me take you back a little bit. You said ultimately you became the chair-elect and the secretary of the ACOG district. When did you first get involved with ACOG?
Well, actually from the beginning. Even before ACOG was started, Don Richardson, who was the exec for the Maternal Welfare Group, Committee on Maternal Welfare, had involved me in some of those activities. And when he came over at the same time about as the exec for the college, he knew me and so forth. And so he had me involved. In fact, I was on the arrangements committee to the first meeting of ACOG.
First, that was been in 1953, I think it was, wasn't it?
Yeah, they were meeting in December then,
yeah.
And later went over to the spring.
It's interesting because you were there under Mingert,
Yeah.
And although Mingert was not the first president of the college, as I've read the history of the college, it seems to me that Mingert was the driving force that made the college, and he hated the American Medical Welfare Committee.
You better believe that.
He wanted nothing to do with that.
Well, it wasn't a physician group, for one thing, and they had made the original definition of puerperal fever and that sort of thing, but they don't think they'd accomplished that much. And of course, when the college started, they wanted a physician only. And originally, actually, any physician who had an interest in obstetrics could become a member of the college, which was the academy then. And it was only after 3 or 4 years, I suppose, a little while, they made it require the board certification.
And getting back to Don Richardson brought you in to help you begin to work.
Yeah.
When did you first enter into the elected portions of the college?
That was after I moved to Little Rock. I began as a local arrangements chairman for the 1962 meeting, I think it was. and then went from that to secretary-treasurer and to chairman.
And when were you chairman of the district?
From 70 to 73.
Did you ever seek higher office in the college?
Not actively. I've always thought I do what I wanted to and see what happens. Actually, at that time, I think people, it was only, I suppose, around 1975 that people began running for office rather than
Being selected.
Yeah, being selected. So I don't know that I ever run because I have enough to do and sort of let things seek me rather than my seeking them.
Jack, for many years, you've been one of the prime representatives of the college to the American Medical Association.
Yeah.
When did you first get involved with the AMA?
Well, actually, it was Woody Beecham who got me involved as a program representative when the AMA was doing clinical scientific programs. And I was representative at the time of the last one, which I said had in St. Louis because they wanted to make sure it was the last one. And with the family medicine group coming up and putting on their own programs, and the College of Surgeons having active programs, and ACOG was coming in, there wasn't that much of a need to have the AMA involved in putting on clinical programs as such.
Historically, OBGYNs have been one of the groups, like the family physicians, that have always been very active in the AMA. Why do you think that is?
Well, I think we've always had a core group of people who felt an obligation to the organization of medicine and seeing that medicine was represented and had both their own specialty, but also that people were making sure that somebody was representing it, and the Ob-Gyn seemed to many people who dedicated much of their lives to organized medicine.
Currently, the AMA is, of course, running into a lot of difficulty maintaining their membership.
Yeah.
What was your analysis of why that is happening?
Well, I'm a little unorthodox, but originally the AMA, which began in 1847, was almost entirely education. And gradually they began evolving. And of course, the family medicine practitioner was the core of medicine up until maybe 75 years ago. Then as the specialists came in, the generalists were lower in numbers, but had accumulated all the power. In fact, when I came into medicine, if you became a member of the College of Surgeons, you had to be a member of the AMA, or you could not be a member of the fellow of the College of Surgeons. And then the state medical society, of course, especially in the more rural states, the family practitioners and the general surgeons who did a lot of family practice then were the main controlling forces. And it was only relatively late that the specialists began becoming part of the AMA. In fact, Tom Nesbitt from Tennessee, a urologist, I think was the first so-called specialist that became president of the AMA.
It's been a lot of changes.
Yes.
A lot of change. Let's go back to ACOG. What other positions besides in the district have you held within ACOG, other than also as our AMA representative?
Well, I was on CREOG in the early days. I was the representative to NACOG in the early days. I represented them after Henry Thied on the American College of Nurse Midwives. I was on the Board of Governors of the College of Surgeons and on the Advisory Council for Obstetrics and Gynecology and Obstetrics. And so a few other just as things came along.
Currently, you're retired.
Yes, as of November.
As November?
Last November.
Last November. Why did you decide to retire then?
Well, I don't know. 65 years as a physician is about enough.
What would you describe as your most, I guess, most memorable experience as a member of ACOG?
Oh, there have been so many. I don't know if there's any one that would stand out there. I've been involved in a lot of things in ACOG. I went through the patient insert that had to be rid of, insert by the patients, and went through the abortion business. It was high at the time that I was on the executive board as chairman, and then through a lot of educational changes, the ACOG and so forth. So I don't know, it's just been so much of a college. It has been, I hate to hesitate one thing over any other.
It's interesting to hear you discuss, because you talk about the really founders of our college.
Yes.
You talk about those pioneers that led us to become what we are today.
Yeah.
You're probably one of those without really recognizing it.
Well, I know I had some correspondence with Johnny Brewer when I gave my central presidential address, which I took some of these things up. He corrected me on a couple of things that I was a little wrong on.
I did find it interesting when you mentioned Fred Falls. I had the opportunity as a medical student to scrub with him on a number of occasions out at West Suburban Hospital.
Oh, yeah.
And he did have his opinion of things.
Well, you know, a funny thing was, almost, I'd say 99% of his operation took the same time, the same step-by-step procedure, and he had that down, and it was methodical.
Oh, yes, he was that and all. Well, let me ask you another question. If you could make a change in ACOG, I said to you, give me one thing you'd really like to change about ACOG, what would that be?
That's a hard question. I think probably to strengthen the sections. ACOG began very strong at the national level and then at the district level, and some sections extremely active. There are some that are still sort of weak, I think, at the section level. And I think one thing that needs to be done is to get the section chairman involved in the AMA and the state organization. Because, for instance, we have the section council of the AMA that meets. But think of if we had all of the section chairmen in contact with the State Medical Association, you know, through personal contact, and much of AMA is through personal contact. Think how many votes we could have by bringing in the state representatives that know our section chairman, that don't know the section council maybe very well. The section council changes pretty fast sometimes, whereas your state medical societies don't. And with our section, people usually being in 3 years as vice chairman and 3 years, they have 6 years in contact with the state medical society delegates and going to that. Think of the increased influence we could have both within the state and also at the national level if we got that real developed.
What would you say that you see as the future of our specialty? Where do you think we're going to be going in the next 5, 10, 15, 20 years?
I don't know. A lot depends on, in the same way on the manpower thing. I've always felt it's hard to say because you don't know to what extent and how we're going to use nurse midwives, how we're going to use the physician extended, the PAs and so forth, how much we're going to do more of the specialists and let the sublease rest. And these are such variables that I don't know that you can tell which direction we're going. And now with all the government involvement, it makes it even more problematic as to where we're going.
It is kind of a confusing issue out there.
Yeah.
You mentioned midwives. What do you think the relationship of OB/GYN should be with midwives?
Well, I think one is we missed the chance a few years back of getting a close relationship by giving them an equal, not an equal necessarily, but there's certainly their share of both power and money. And if we'd done that as a team, I think we'd be much better off today. I think we are going to have to evolve as a team. And I think, well, at our place we have, I think it's 4 or 5 nurse midwives on our faculty, and they're very helpful. And it complements the residency program by not having as many normal deliveries, but we're getting all the complications out of that group. And I think we're going to do that. We also have a PA who is very helpful. And so I think the team approach is going to be. A big question is whether we're going to go over towards the hospitalist concept of the obstetrician, where one doctor will be on call in the hospital and take all the deliveries for the group on that period of time, or where we're still going to try to give a little bit more individual care. You're going to have to decide a trade-off on those two.
We're seeing right now that our specialty is becoming much more female.
Yeah.
Matter of fact, in the last match, almost 80% of the incoming residents will be women.
Yeah.
How do you see that impacting on our specialty?
Well, I think it's going to be several ways. I think one is it's forcing us to be a more family-centered residency, which is not all bad. I think it is causing us to look at shared residencies and things of that sort that are going to be coming along, and a little bit more we're going to have to face that issue a bit more. I think that the hours working, the 8 hours, one thing, but even that I think stresses some of the women. It brings up the reentry program if they take time out, even just for even the latter part of pregnancy and then come back, or if they take out a few years to raise their children and come back. We're going to have to look at reentry and finding a way to keep them up during that period of time. They're not in active practice, but can keep up the skills and so forth in some way, or maybe even work out some system where they may be just doing a certain amount of practice to keep up the skills. But we have all these issues that are going to be very important.
We have some workforce studies which indicate that within the next 20 years, our relationship or ratio of OB/GYNs to females in the reproductive ages will drop by about half.
Yeah.
And it's going to need others. So how do you think we should try to encourage our fellows? Because, as you know, there's a lot of resistance to using anything other than a trained OB/GYN.
Yeah, I know, and we've gone through a lot of that with the primary care thing, and I don't know how much was settled, but I think we're going to have to look at it and probably give choices. Some will go one way and some will go another way. We're going to have the issue of whether we're going to change the residency program to different tracks, or whether everybody's going to take the same track and then go into Leon Israel wanted to call them supra-specialists. He didn't like subspecialists at all. He thought it was over and beyond the usual residency, and he liked supra-specialists. But all these are up in the air right now.
If you could be a guru that would oversee the development of the entire specialty, how would you structure it?
Well, I think I would probably have more of the what's now subspecialty into general education, but also have some super specialists to do the ultra. Take pelvic relaxation. We have residents who come through and they don't want to, the minute they get out, they don't feel comfortable doing it anymore. And they should feel comfortable for the so-called bread and butter group. And They're getting that with ultrasound. They're doing much better in getting a broad knowledge of ultrasound than they are in pelvic surgery. There are going to be some, like, if you have fistulas and so forth, that may require a little bit more experience with limited people doing them. Whereas your pelvic relaxation and urinary incontinence, I think we're going to have most of the general residents getting. And residents sometimes change their mind after they get out. In fact, we've had two going into anesthesia. We had one chair of family practice that came into our residency program, went into OB, and even after the residency and practice, there are some people who change their minds as to what they want to do. And I think we have to be more broad in the way we look at things rather than coning down and becoming less and less about, more and more about less and less.
Given the opportunity, what advice would you have for a young physician in our specialty today?
Well, I would say that, and I think it would hold true not only our specialty, but in any specialty, including family medicine, that you should have one area that you feel you're better off than other people, better trained in, and so forth, to give you that little boost of I'm a bit better here. And in addition to be a good generalist. And I think we're going to see things changing. We just seen change so much. When I had an OB, you could carry on a good quality practice with a bottle of failing solution, a little sulfosalicylic acid, and a fetoscope and a blood pressure and a stethoscope. And literally, we didn't have ROGAM, you didn't have ultrasound, obviously, you didn't have all these other things. And so I think they're going to have to be prepared to keep up with what the newer things are. In fact, in general business, they say that a person's going, just like he changes homes every 7 years, he's going to change his specialty, his practice every 7 years because of the changes that are coming on. So I think the main thing is you've got to be adaptable, and you've got to spend time keeping up.
Well, thank you very much, Jack. It's been a great pleasure to talk to you and to get some insight. And actually, you have some very interesting insights into the early history of our specialty.
Yeah, it was quite interesting.
And we appreciate very, very much your willingness to be interviewed. On behalf of ACOG, thank you very, very much.